Okay, it's a little early for Halloween, I know. But anybody know what I'm representing? And if I've already told you, you're ineligible to answer. Yeah, a pediatric nurse. Yeah, right. No, I'm Dr. Doolittle. Yeah. And I don't know if this will go into the mic. You like those props? Yeah, I raided my son's stuffed animal collection and snuck them into the suitcase to bring here. I actually did a training day at ScanSource in the spring, and all of the team wore scrubs, and I told them I'll take any color but yellow. Well, my second least favorite color is pink, so I had to do something to accessorize it. So. But yeah, my name is Vivian Funkhouser. I work for Motorola. I manage the health IT vertical for Motorola. I've been in healthcare in marketing and sales. I am not a clinician by background. I've been in marketing and sales in healthcare for more than 20 years. So I'll just leave it at that. Started in pharmaceuticals, went to devices, got into health IT, working for McKesson, and then here I am, working over on the hardware and the device side. So I thought that our presentation by Onvia was a wow. Wasn't that good? It was such an eye-opener. It was, yes. I learned a lot. I have always practiced in the private sector. My sister worked for a community hospital, a community college, and was always in the public sector and worked in the government. And when we would get together for dinner, we would just shake our heads because we couldn't work in either one's environment. And from what I heard, it confirmed I don't think I could work in that environment. But I fully respect all that's going on. And yes, there are funds available, but it is a complex environment. Coupled with that, healthcare is a complex environment. So I think it's pretty natural that we put those areas together. Healthcare, like government as well, loves acronyms. So as I go through this, if there are acronyms that are not familiar to you, this is a small enough group and informal enough, and I take this all as a learning curve. So stop me and say, whoa, wait a minute, I haven't had enough coffee to really figure out what that acronym means, and we can certainly take a minute to decipher that. So just as my colleague in Onvia started, I'd like to start and get a baseline here. When you hear healthcare, not from a consumer patient standpoint, but from a business standpoint, what do you think about? Anybody? What do you think about when you hear healthcare?
Complexity of it all.
Complex. Anybody else?
HIPAA.
Yeah? HIPAA?
Slow pay.
Slow
payers.
Oh, slow to pay their bills type of a thing. Yeah. Anybody else? Hospitals. Okay. Good baseline. Yeah. Complex, slow to pay, doesn't really vary a whole lot from government, does it? In a positive way, okay? What I am going to be talking about today is taken from a course that I developed for a trade show earlier this year in the spring called the Unsummit. It is a very focused group just for point of care that teaches and advocates the value of a barcode for patient safety initiatives. Only about 300 people attend, all heads down on getting barcodes to the bedside and supporting clinicians in the work that they do. So the course that I developed for this trade show turned out to be a CE course for continuing education credits for clinicians. It was presented to pharmacists, and for nursing. So this is something that I make available around the country for different states, for different professional organizations. And ScanSource, when they saw it at the Unsummit, asked if we could duplicate that here for you. So everything is the same. The only thing I did is I changed it from the theme that we had at the Unsummit, which was catching errors, from the baseball theme. And that was my disclaimer that I gave. So when we think about what's happening in healthcare today, specifically in the hospital environment, you know what? The clock is ticking. They are racing towards the adoption of electronic medical records. And just like government, there are a lot of buzzwords that are around that. A lot of them have to do very simply with patient safety. And so when we sell into the hospital environment in these clinical type of applications, and we're measuring our success on patient safety, it's not a hard dollar ROI that we're after. These are soft sales and really quality outcomes that they're trying to get to. And these are some of the requirements and the compliance that is around this in the next 24 to 36 months to deploy the electronic medical records. What did I do? And so what are they trying to do in reaching their goals? You saw the activities on the previous slide. Some of the goals are really not in a hard dollar ROI for patient safety, but really to improve patient care, quality outcomes, looking at efficiencies in terms of what we put in the hands of nurses, physicians, clinicians. You know, I say in a mobility strategy and in these deployments that the goal should be to allow clinicians to focus on care rather than focus on technology. Today, unfortunately, they're focusing more on the technology that then supports care and compliance, but not necessarily on care itself. You know, even if you look at the physician application of CPOE. CPOE, anybody know what that is? Computer physician order entry. So where they're taking the physician diagnosis from a paper verbal environment and putting it into an electronic environment. Just for CPOE, and you think physicians are pretty savvy. The learning curve for a CPOE project, just to get back to net of how much time it takes him to do his job, from the time of implementation to getting back into his routine. Do you know how long that takes? 10 months. So that tells you when we're moving towards these electronic, moving away from paper, you know what? It is a very complex process, yes. And we can't necessarily tout hard dollar ROIs because, bottom line, it slows them down in the process. But these are some of the goals that they're trying to reach. And so there are steps that facilities should be looking at, and the value add from the integrator community is that you become the outsourced IT department, the extension of the IT folks. I always tell people, your job is to make IT look good. When you're the value add beyond supplying products, when you're the value add in making IT look good through this project, by taking off some of the load, by rolling up your sleeves and doing some of the work, and helping the facilities comply and get to their goals so they can get their reimbursements and get paid in a more timely fashion, then you know what? You're going to get subsequent calls. Healthcare is difficult to work in. It's a long sales process. But I think that those of you who are in that will also say, once you get that, they're very loyal. You get repeat business, so long as you're there adding value. They want somebody local. And so I'm going to take you through these different steps of what hospitals should be looking at in their electronic medical record deployment from beginning to post-deployment activities. We developed a white paper on best practices of EMR deployments that certainly is a tool that you can leverage too in these discussions with facilities. And so in the general planning, what are some of the things that facilities should be looking at? You know, we often look at a project and we silo out that project. Okay, I'm going to deploy the lab this year. That's what I have funded. But it's really a matter of looking at the strategic plan for the entire facility and how does this slot into helping them meet their goals in the strategic plan, for example. I was just at a academic facility about 3 weeks ago, and they are getting ready for an EMR, an electronic medical record, deployment. And I talked to them about a mobility strategy. Well, in their mind, when they were thinking mobility, they were thinking cell phones coming into the facility that the physicians are bringing. Yeah, that's one component. But there's a lot else around that. It's the devices that are being used within the facility too. And what are you doing to make decisions about a one-device multifunction? There's data management. There's voice. There's being able to access libraries, drug reference libraries. There is email. You know, that all goes into a mobility strategy. And then how does that roll up into the strategic plan? There's nothing more important than the internal PR. You know, there's an assessment that senior management needs to do. Are these folks ready to move away from paper? We call paper the security blanket. And when projects are deployed, there's about 2 to 3 weeks where they often will allow that dual workflow because they need to gain confidence that the electronic system is really capturing all of the information that they need. So they carry the paper in a duplicate as their security blanket. But before they ever get to that point, senior management should be assessing whether the facility and the staff are ready to go from paper to electronic. I'll give you a little bit of the profile on the demographics. The average age, and I'm talking about nursing here, the average age of a nurse in a hospital is 47 years old. The average age of a nurse in a long-term care environment is 51 years old. The average age of a nurse in home health out in the community is 54 years old. Now, knowing that's the demographics, what happens to us? I'm in that age group. What am I doing? My husband says for my birthday he's going to get me longer arms. So when we're moving these workers from a paper-based system into an electronic format, what is it that we're putting in place? Whether it be clinical or not. Think of cleaning staff as well. What are we putting in place in that PR to be sure that we're gaining their confidence? Because what's the worst thing you can do is say, here you go, I'm shipping it, landed, you deal with it, ready. Put it in their hands. And you know what? Do you think that they blame the software vendor? Or it's not pinging the network and it's the network's fault? Nah, they don't know the differences, and nor should they. But they see the device, and more often than not, just like we do with our phones and such, we blame the device. And honestly, Motorola has their little bat wings on there, so I get blamed a lot. So that's why it's important, and I work with facilities, backing it up as to what this project looks like, and looking at across end to end. Because we always say, the device and mobility is the end goal. But what's happening to be sure that once we get it into the hands of the users, that we have prepared them and brought them along and gotten them used to it so that adoption is better. Even in physicians' hands, and you think of physicians as being more tech savvy, they love gadgets, but it's a try and buy sometimes. And compliance on CPOE is in very few places at 90% or above. So there's the strategy of creating champions, early adopter programs, pilot programs, whatever you need to do to bring along. Also, if you're working with nurses, think about it. Nurses are the largest employment pool of a hospital. They might not have all the power, but there's a reason you want to try to keep them happy. Because with the nursing shortages, they can go work someplace else. And when I first started in this business about 10 years ago, and we were attempting to educate facilities on taking a barcode from the grocery store and putting it into a hospital, there were nurses, certainly, that would threaten, "I'll leave before you make me use that." But there were also nurses, and it usually took only 4 to 6 weeks for your worst devil's advocates to turn around and become a champion because they had an epiphany. Somewhere in their shift, the electronic system helped them avoid a mistake. Okay, moving on to, we've talked about the planning stage of it. So the next is to be sure that the infrastructure is ready to support mobility. And there's a difference in the infrastructure ready for a data deployment and an infrastructure that is ready for a voice deployment. Any of you who have worked on the voice side of the business know that, and I tell some of the teams often, if you want to be a hero, walk into a facility, any type of a facility, that has recently deployed voice and didn't do a wireless survey first. Oh my, are they in pain? And you can certainly be a hero by coming in and fixing things and getting it working again. But it's really an evaluation. Do they have wireless? Is it house-wide? How old is it? Not if they have dead spots, but where are the dead spots? And IT certainly knows where those dead spots are because they get the calls. Linking this again into the strategic plan is what is their plan for mobility in 3 years? What is the voice plan for voice enablement inside, outside? What are the security protocols? What about guest access? So a lot of questions to ask to start probing about the integrity of the security and of the reach and the reliability of the wireless infrastructure to be sure that facilities are getting ready for a mobility deployment. And then extending that out is also talking about the security of the network, but also scalability. Again, when you're thinking about adding value, it's looking at the project today to help them grow into tomorrow. A lot of facilities today, the trend is, we're going back really to the early 90s, where hospital systems are starting to envelop and own and extend their reach out to the clinics and the physicians' offices. Until recently, those were pretty independent, but they are being enveloped into and brought into the hospital system. So as facilities are looking at their wireless infrastructure, link it back to the strategic plan again. What is their plan for expanding their business, for acquiring other businesses in the community? Even if we look at long-term care, one of the ways that long-term care is going to survive is to become bigger and to become conglomerates. So you may identify opportunities with long-term care facilities but link into what their future looks like for investment so that you can be sure that their wireless strategy is scalable. Some workflow considerations when we're looking at the different types of workers in a healthcare environment. It's very important to understand that the different environments have different needs. The way that a NICU nurse, a neonatal ICU nurse, works is very different from the way a step-down med-surg area works. Their requirements are different. Their needs for mobility are different. Their patient-to-nurse ratio is different. So it's important to get in and do a workflow analysis to help get into those details of what it is that are their mobility needs based on the different environments and the workflow. It's important to also know the constraints as to what else do they have in their hands, for goodness sake. And if they have other things that are in their hands, what are you going to do if you put a big iPad in their hands, for goodness sake? Then what do they do with their hands? What do they do with carrying everything else they have to carry? Which is fine. But if you think through the workflow, okay, so we give them an iPad. And I'm going to go to the nurse. So when the nurse walks into the room, she's got her iPad, she has her meds, she has her stethoscope around her neck. She's got to have a barcode scanner on that iPad as another periphery. So she's got two hands to juggle all these things, right? What does she do? She's got to put something down. What does she put down first? The iPad. Where does she put it? On the bed. I gasp when I say that. Do you guys know why? Germs, 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 germs. And if she's going from that patient room to the next patient's room, to the next patient's room, to the next patient's room, and putting it on the bed, boy, she's picking up little creatures along the way. You know, MRSA is a very serious, and I don't over scare people. One of my neighbors, bless her little heart, a very healthy 94-year-old lady, fell and went into the hospital for 3 days. And unfortunately, she came out worse than she went in because she got MRSA. So early in the process, be sure that infection control is engaged. I think the screen size and the real estate on an iPad is great. It doesn't necessarily match the workflow needs. So walk through with the clinicians. Clinicians love it when you come in and shadow. They love it. Every job that I've ever been in, when I start my job, I spend the first 2 to 3 weeks just shadowing. When I sold into the OR, I shadowed anesthesiologists. I hung out in the emergency department. They were so excited they had a gunshot wound coming in when I was there. It was the little country hospital, and they don't get those very often. But healthcare, and it depends on the size of the facility, of course. But look at your community hospitals. They're eager to have you as an extension of IT to be able to roll up your sleeves and provide these services. And you know what? You can bake these services into being able to charge. Sometimes when I do workflow assessments and evaluations, I let them know the value of what I'm going to do. And sometimes I offer it free. Sometimes we put it into the contract. Sometimes I let them know that my partner or my territory guy is going to pay half. You know, there are ways, you certainly want to add value, right? You don't want this to be free. Where I often spend most of my time in evaluation in this race for adoption for patient safety initiatives is on the nurse and evaluating her workspace. And then that leads into the different constraints of the environments. And so when we're looking at specifically POC is point of care. And if you think about point of care, this provides, I'm talking a lot about hospitals, but point of care provides great opportunity for everyone in providing mobility and moving from paper to electronic. Because if you think about the definition of point of care in its broadest sense, point of care is a licensed clinician touching a patient wherever that care occurs. Let me say that to you again. Point of care is a licensed clinician providing care to a patient wherever that care occurs. And we have traditionally limited that to the four walls of a hospital. And that's not necessarily the case. It can be a physician, it can be a nurse, but it can also extend out into the community. Those of you who are on the state and local side, don't forget, the EMTs are a licensed clinician providing patient care where that care occurs. And they're hungry for electronic tools. There's nothing more critical than what they call that golden hour of being able to share data, send data, receive instructions, provide real-time, up-to-date EKG reads en route. And so when we look at point of care opportunities, and I'm going to go back to the hospital environment because these are the early adopters, it has become what I call a hybrid workflow environment. You know, the software is the same across the facility, but the hardware needs, it's not a one-size-fits-all anymore. It used to be, just as recently as 3 years ago, it was that the software vendor would come in and say, here's a little package, this is what we sell you, take it or leave it, bye-bye, I'm out of here. Done. It was almost a solution in a box type of a thing. But as healthcare facilities have started using these applications and coming up to speed and the consumerization of devices or whatever you want to call it, they have become more critical, more tech savvy, and more demanding among the software vendors saying, this workflow doesn't work across the whole facility. I need it this way in ICU, and I need it this way in the emergency department. And you, Mr. ISV, you make it work for me, because that's what I need. My nurses are screaming at me that this doesn't work. And so because there isn't this nirvana of a device that works everywhere, it's become a hybrid hardware environment. And by that, I mean there are these different types of workflow tools. In a patient's room, you may have a wall mount, and that is each patient room has a monitor in the room that is linked to that patient, or if it's a semi-private room, to those two patients. And I'm going to go through the advantages and disadvantages of all of these. The advantage of the wall mount is it's there. You know, that example of the nurse having to carry all these things into the room, that goes away because her clinical application is right there. She can walk into the room, pull it up, and then eliminates the infection control risks because it stays there. Okay? Great idea. Let's talk about the disadvantages of it. Anybody want to offer any?
It's not mobile. You can't bring it to the patient.
That's right. You can only get it so close to the patient. You know, that arm sometimes will swing out, but it still involves steps. And it still takes the clinician away from the screen and what's happening on there to go to the patient. Another disadvantage?
It's not portable, so it's more expensive than having
Woo!
a unit in each.
Oh, yeah, baby. Yeah. The facility is certainly increasing their deployment costs with this type of from our perspective as integrators, that's great, right? But certainly increases the budget needs whenever they're putting this in every room. Another disadvantage, and this came out of the learning curve because facilities thought this was a good idea. Nurses thought this was a good idea. And in the end, the nurses hate it because they can't step away from the patient and the family to get their work done. Because they're right there, they're getting interrupted with questions. They're getting conversations. They're getting pulled in. They can't step away to do their work. So they've ended up having to duplicate this and add more hardware by putting it back out at the nurse's station. Kind of defeats the whole reason for going to this workflow, right? Yeah. It is a good idea. It works in certain areas. I think it's great for such areas like ICU, where that patient to nurse ratio is very low. And I don't mean this in a negative way, but a lot of times the patient is sedated and can't have a conversation with you anyway. And the families, yeah, their control of visitation hours as well. So she's able to get her work done. It's right there. It's very close. She's not taking care of too many patients, so she can do it. Okay. Oh, why do I keep pushing that button? The other one is the mobile workstation. This is the workhorse here. Yeah. Anybody know affectionately what this is called?
Wow. Car on wheels.
Yeah, it used to be called a cow. Today, let's be politically correct, we call it a wow. Okay? So the cow was a computer on wheels, and that really didn't work politically. So now it's called a WOW, a workstation on wheels. One of the clinical vendors tried to coin the term BMW, barcode mobile workstation, but that didn't catch on. So yeah, it's more affectionately called a WOW today. The general workhorse, this is the most common deployment for nurses for their clinical applications. You'll see it everywhere. The ratio is usually a 1 to 3 beds will have a workstation on wheels. Okay? Disadvantages, anybody?
Space.
What do you mean by space?
Moving that inside of the patient's room.
Weight, yes.
They're not cheap.
They're not cheap. But, you can start with the cart and then all the stuff you're adding onto it. It's a great sale, but you know what? It is expensive. If you're looking at, for example, such things as what Motorola sells, the mobile computer, and you get pushback on a mobile computer, just price out one of these babies.
You have the same infection control problem that you would say.
Ooh, yeah. Yeah, infection control, somebody said. Yeah, going from room to room. Now, granted, this is not necessarily touching the patient or being put down anywhere or something. But the infection part comes from the scanner that they typically have housed on these. And we'll get into, do you go corded or cordless type of a situation. Yeah. Okay. The other thing is, you talk about expensive learning curves. I was working with a facility. There are 13 hospitals in the system, and a lot of them are old hospitals. And they did a big bang rollout, which means they bought all of the peripherals and all of the equipment, and they were going to bring everybody up at the same time, on the same day. Do you know what happened?
Wireless infrastructure couldn't handle it.
Well, that's definitely, you want everybody on staff, want all hands on deck.
They went down the same day.
Probably. But even before they got there, gee, nobody measured the doorways. Some of these hospitals were built in the 1920s. Some of those carts couldn't even fit in the room. Oops. Another reason to do a workflow analysis and think about those details. Yeah. Hopefully they saved all their receipts and all their manuals and still had warranties so that, or somebody had to eat a pretty big chunk of dollars. The tablet. The tablet is, I believe, it answers the question for those that are screaming about, my eyes can't see this, or the limited real estate, or the clinical applications that really don't port well to a small screen, and being able to view the patient information and really input your clinical documentation. A lot of advantages for the tablet. One big disadvantage we already discussed was that spread of germs. I believe that devices should be pocketable. If you really are looking at taking this from room to room, you should be keeping it on your person, and you should be putting it. When I give ideas to my product development team, I give them a smock. And I say, you see the size of this pocket? It can't be any bigger than that. Now, with some of the new devices, that leaves it pretty open, right? You can get some good screen size on some of the devices. Beyond that is you also need to be sure that they can be sanitized. And what is the testing that has gone into that? You can test something for 3 months, but the life of these devices in a healthcare environment should be 3 years. And are they going to be able to withstand wipes between patients? Oh, maybe 40 or 50 times a shift? And there better be testing to go around that, or somebody's going to eat when those devices start failing. Also, just in general, can it withstand the clinical workflow? What are the drop specs on it? We're all about this shift to consumerization, and you start hearing the BYOD. I really like that, the BYOD, bring your own device. But even as facilities are making decisions on behalf of their staff, they're thinking a consumer device is appropriate. Yes, probably appropriate for about 4 months. What is pictured here is the Motion C5 tablet. And that was launched at the 2007 HIMSS conference. I forget what city. I think it was in Orlando. I can't remember what city it was in. And the Motion folks had planted them around the show floor, and IT folks were enamored because they were getting the pushback from nursing saying that the limited screen size, and everybody thought this is the answer. And when I talked with some of the companies, the integrators that were representing this into healthcare, I think 6 months later, they were experiencing a lot of repairs coming in because it was a great idea, but I'm not sure that there was true analysis of the workflow to be sure that this was appropriate for this environment. They've subsequently come out with much more rugged type of versions of the Motion C5. But sometimes when facilities are making a consumer decision, I fully respect that. But I also put that on my calendar because I call that an expensive learning curve. I'll be back in about 18 months to see how happy you are. And I would tell you to do the same. There is a place for consumer devices. Let's look at that workflow. When is a consumer device appropriate in a healthcare environment?
Desk situation.
A desk situation, sure. When it's your own personal device. Because you know what? You take better care of it. You're less likely to put it down. You'll put it away before you put it down, right?
You see those in doctor's offices.
That's right. So that's why the tablet is more appropriate in a physician workflow than it is in a nursing workflow. Because the nurse is not going to really own that device, and she's got too many other things that her limitation of 2 hands has to carry. A physician, on the other hand, he's got all of his entourage around him to do all the carrying. So this may, the tablet workflow and a consumer device works well for a physician because they typically will own the device. It doesn't for other workers and other clinicians because they don't own the device, and based on their workflow, they have to pick up and put down and do all of those other things. The desktop, okay? Advantages of the desktop is it's there, we know where it is, all of your stuff is centralized. You don't have to worry about that infection control because it's not really in front of the patient, unlike the wall mount. I'm differentiating from the wall mount here. We all have our desktop in our office or wherever, and then we have our mobile component. Disadvantages of the desktop.
Takes a lot of space.
It does take a lot of space.
You have to bring things to it instead of it going with you.
Right. It takes the clinician away from their patient because the desktop in a nursing unit, the desktop is usually at the nursing station. So what is she doing? And this is more of the traditional workflow. So what is she doing? She's taking her paper into the patient's room, or she's taking her memory, her 50-year-old memory, into the patient room, doing all this, and then removing herself from that environment, batching it in her head, and then recording it later on the desktop.
Well, you see that in labs a lot.
It is in labs, and it is an advantage in labs because they have limited workspace in the lab. So even when they do have a desktop in a lab, you also see it in the pharmacy. They don't have very far that they're moving anyway. So they can access it very easily and very quickly. Again, and that's a good point, Rick, because it brings up, again, that workflow analysis. It is appropriate in some cases to propose this in this hybrid workflow environment, hybrid hardware environment. And then, of course, the mobile computer. Advantages, because it's mobile, it's getting in and out, small enough that it's pocketable, so she doesn't have to put it down and get it contaminated, although, they do put it down. It can be wiped down and sanitized. Disadvantages. Screen size. Yeah. Anything else? It can be lost, misplaced. If it's very sexy looking, it can also be stolen.
There's hardly input as far as the keyboard goes.
That's right, keyboard limitations, yeah, which is like why they like having the wall mount or the computer on wheels or the desktop. Yeah, is for input. Mm-hmm. Very good points. The other thing to expand from that, when we do our workflow analysis, the mobile computer is appropriate in that 80-20 rule. If 80% of the workflow is click and go and pull down and on to the next screen, and it's only 20% input, that's appropriate. If it's free texting and a lot of numbers and, you know, a clinical evaluation, it's really mean to try to push a clinician into a mobile computer to do clinical documentation and input. And that's why in the trend, it has become this hybrid workflow environment. There were some clinical vendors, all they did was deploy with a mobile computer. And so they had to do all of their clinical documentation. And that was before all of the texting was popular. Or they did a workstation on wheels, and the nurses were forced to push this around during their shift. The other thing with the workstation on wheels, you'll find the hazard with the workstation on wheels is they end up in the hallway. That's a fire hazard. It's also a risk of compromising patient data, HIPAA compliance issues. It's also not always plugged in. What do they have to do? When they have a workstation on wheels type of a strategy, minor detail, but very important and labor intensive, they have to move all of the outlets from down here to up here. Because I can tell you, a nurse is not going to bend down and plug it in. You better make it easy. Okay. Oh, my palm keeps hitting the center there. Okay. So this goes into some of the details of this hybrid workflow environment. The bottom line is we want to be able to maximize functionality in conjunction with respecting those workflow constraints and that workflow need. And maximizing functionality is packing in multiple applications, possibly, looking at, as I said, the doorway, if it's going to fit. When you're looking at a workstation on wheels specifically, what are the mounting options for that scanner? When Motorola was getting ready to launch and actually go into product development for our healthcare specific scanners, we went out and I had my engineers interview nurses and IT folks. What are important features for you if you're just looking at the workstation on wheels workflow? For data capture, what's important? You know what nurses told us? For the cart on wheels, this is my workspace. Don't mess with it. Prime real estate for, and it's not very big. You know, some of them can be big, but then you have that weight issue of trying to push them. So they try to keep them portable. And so there's limited real estate even on the top there for them to work on. And nurses said, don't mess with that. Don't give me a big bulky scanner that then I have to mount there and it takes away from my workspace. Okay, we put that in our mind. When we asked IT, what is important for your scanner on the cart? Do you know what IT told us? Charging. I need another outlet just to charge the scanner. So when we went into product development, knowing that these were important items on the wish list for the users and the decision makers, we designed the scanner with flexible mounting options. You can even mount it on the back of the monitor if you need to, so that you're not taking up that nurse workstation. From an IT perspective, we addressed that need and eliminated the power cord and gave it instead a USB so that it plugs into the laptop that's on the cart. And then that goes into just needing one charging station. In terms of even buying a cart, there are a lot of different factors involved. This particular cart has a lot of drawers on it. So again, in workflow analysis, there are centralized med supply rooms that nurses would go to get their medications and get their supplies and then take it to the patient bedside. This type of workflow is where all of the patient meds and things are put into the drawers for the shift so that pharmacy techs are supplying the drawers individually. I'm not going to go through this. This is very important, though. I've done brainstorming sessions and courses with facilities on the difference between a linear and a 2D barcode. You want to add value? Just talk to them about their barcode strategy and the difference in the tools. For barcode data capture, we're also looking at different things to do. We all think of scanning a medication. We can also look now at DPM for particularly the OR in tracking some of the instruments that are used in the OR. Also looking at document capture. If they do still write prescriptions, being able to capture those. Okay. Choosing between a linear and a 2D scanner, more often than not, facilities are looking at 2D, not linear, just moving forward. We are doing them a disservice if we allow them to stay with a linear barcode scanner. GS1 standards and such are pushing them into 2D. I'm not going to go over this specifically. It's really looking at, I said I would mention the difference between a corded and a cordless. That is a matter of workflow preferences. There are pros and cons for going each. Some facilities insist that it will be corded. Personally, in the workflow analyses I have done, I always recommend a cordless barcode scanner because there are too many other things going on in that room for a nurse to try to yank a cord across a patient. And also, it's just something extra to clean, for goodness sake. So eliminate it if you can. And then post-deployment. Once everybody's all up and running and the wireless didn't go down and they didn't get frustrated and everybody's happy and everybody's in compliance and scanning and it's over 90%, there are things that facilities should be doing to be sure that it remains a no-fault atmosphere, that it continues to be a learning environment, and that they are bragging about these patient safety initiatives that they've put in place. And so some of those listed here is to do some internal PR among the team, but also some external PR out into the community. And we help with that. Whether it be through case studies or webinars, I'm a big proponent, whether you win a facility or lose a facility, get a lessons learned out of it. And then finally, I want to be sure that you have access to other resources that help support the messages for healthcare environments in what they're trying to do. Zebra is here today, and there is a Zebra white paper around patient safety and the wristband. So these are available out on the web, and I know that Zebra and Motorola can also help get you these white papers. And then if you want to have further discussions, these are some resources for you, both from ScanSource and from the Motorola side, to talk it further. I will also just tell you in wrap-up, I manage health IT at Motorola for North America. I see my role, somebody introduced themselves in my company last week as primary evangelist for healthcare. I'm passionate about what I do, but also if you're moving your business from another vertical into healthcare, please realize that I'm a sales tool to help you extend your revenues and build your business. I don't necessarily have the bandwidth to individually communicate with each of you, but this is your first point of contact to start building out your business plan, looking at your core competencies. And there's a course that I offer through ScanSource that really is evaluating your skill set and leveraging that into how it translates into healthcare for 2012. However you define healthcare, keeping in mind the definition of point of care. So Dr. Doolittle will be around the rest of this afternoon to talk with you more one-on-one, but please be sure that you also tap these resources to take some of this and massage it a little bit and really leverage it into a practical business plan for 2012. I know I ran over, and Nathan, thank you for holding up your iPad to show me the time, so I apologize that we ran over a little bit. Okay.